Good afternoon. My name is Danielle Lombard-Sims, and I'm the Interim Vice Chancellor for Institutional Advancement. I'd like to thank all of you for joining us today for this afternoon's Lunch with Leaders event. Our Lunch with Leaders events are designed to keep our closest friends, alumni, and donors connected and informed during this time of social distancing, and we hope you find it helpful. If you haven't yet had the opportunity to submit your questions for today's presenter, you may do so at any time during the event by emailing iaevents@uams.edu or by using the Q&A feature in Zoom. Today, we have the pleasure of welcoming Dr. Larry Barnes, Chair of the Department of Orthopedic Surgery and holder of the Dr. Carl L. Nelson Distinguished Chair in Orthopedic Surgery. Dr. Barnes is widely recognized as one of the foremost joint replacement experts in the nation. He lectures nationally and internationally on total joint replacement surgery and has published over 250 peer-reviewed articles. He is an active researcher with grant funding, holds 4 patents for orthopedic surgery devices, and has designed numerous hip and knee implants. He's here today to talk about the growth of UAMS orthopedic programs over the past 6 years and to share exciting plans for program expansion across the state. So without further ado, please allow me to welcome Dr. Barnes, Chair of our Department of Orthopedic Surgery.
Thank you very much, Danielle. It's really a pleasure to be here today. Please excuse the look. It's my OR day, so I operate here on Tuesdays and Thursdays at UAMS, and so we operate this morning. I'll go back this afternoon to complete the day. It's always good to have the opportunity to talk about orthopedics, and especially orthopedics here. I will try to keep it under the time limit. To the dismay of my bosses, I can talk about orthopedics about all day. I've been very fortunate in the move here. I moved here 6 years ago. I'd been in private practice for my career, been practicing in Little Rock, running a large subspecialty orthopedic group when I had the opportunity to move over as chair. So when I refer to things before I came, et cetera, please realize it's not because it has anything to do with me. That's just the timeline from 6 years ago to now and what we've been doing. And none of this would have been possible without some incredible support that we've had. And I was very fortunate at the time that the chancellor at the time, the dean at the time, that was Dan Ron, Rick Smith was the dean, and Roxanne, I'm going to go blank, Townsend was the CEO. When they asked me to be chair, they had, we negotiated for about 7 months to make sure that we could come up with a plan that gave orthopedics an opportunity to be extremely successful here. And because of that groundwork, we've been able to. So we truly want to be the world-class orthopedic center in Arkansas. And we expect to treat patients not just from our state, but from the surrounding states, and we do. We have very much a subspecialty focus and expertise. As you'll see when I share my team, everybody has a subspecialty. That means that they've done an extra year of training in orthopedics in one area of orthopedics, and they limit their practice to that. If you do the same thing day in and day out, you get pretty good at it. So it's important to us that, that we're the leaders in our subspecialties for our state and region. We certainly have a culture that believes in innovation and collaboration with others, as I'll show you. And we have great educational programs for our residents and our students. And we believe that one of our missions is also leadership development. We may have an opportunity to talk some about that. So we have grown significantly. When I joined the department, I was the 12th member of the orthopedic department. In about 6 weeks from now, we'll have 41 members of the orthopedic department. So we have grown significantly, and that just includes the doctors. We also now have 12 to 15 mid-levels in our department, which are new. And mid-levels are PAs, physician assistants, and advanced practice nurses. So truly a team approach toward care. We also have 2 fellows. So just as we've gone and done fellowships, we now have docs doing fellowships here. We have a total joint fellow and a spine fellow starting in a couple of months. and we have a number of collaborating research faculty that we'll talk about. We represent the non-subspecialties of orthopedics. There's not a single subspecialty in orthopedics that we do not have here, and fortunately, we have had 2 in each of the subspecialties, and we'll discuss that. One thing we've done has really grown our clinic locations. We have a distributive model of clinics. That means that other than tumor care and trauma care, our clinics have moved off campus. Our patients find that to be a very friendly approach. So we have offices in Central Arkansas and offices in Northwest Arkansas that you drive up to the door of your doctor's office. It's just no different than if you're going to a private practice clinic. And our patients like that because, you know, if you have an orthopedic injury or malady, especially one affecting the lower extremities, and you're doing a lot of walking, it's nice to have easy access to the office. In addition, we have non-rehabilitation or physical therapy locations in the Little Rock area and in Northwest Arkansas. I keep referring to Northwest Arkansas. As many of you probably know, we were fortunate enough to be able to open a clinic in Northwest Arkansas, and it has been a great addition to our department, and we'll talk more about that. As I told you, we believe in quality care, and we've been lucky enough to be recognized by Health Grades, U.S. News and World Report, and Blue Cross and Blue Shield in their awards that look at quality. As you'll note, these are about joint replacement and spine. That's great, but your question is say, hey, what about all those other subspecialties? You have 9 and only 2 of them got awards. That's because they only give awards in these 2 subspecialties. I have no doubt that if they gave awards in the other subspecialties, my partners would be winning those awards as well. So let's talk about the team. And when I talk about these folks, I refer to them as my partners, not as my faculty. We truly do the same things. Obviously, I'm here today after I've been operating for the day, and I believe that as a leader in the department, it's important that I am doing what my partners are doing if I want to have their respect. From the joint replacement section, as Danielle was kind enough to say, I am a part of that section. I'm accompanied by Simon Mears, Jeff Stambaugh, and Ben Stronach. Ben just recently joined us in January as a mid-career move from the University of Mississippi. We've been friends for a number of years, and we're excited to have him on our team. Jeff did his fellowship at Ortho Carolina, one of the premier fellowships in the country, and then joined us. So and then Simon Mears, we go back a ways. We met in India doing a mission trip called Operation Walk, and I quickly saw what a great surgeon he was. I enjoyed being around him, and soon after I moved to the university, I called Simon because he was doing private practice work in Dallas after spending his career at Johns Hopkins. And I called him and said, listen, Simon, when you get bored in private practice, let me know because you should be in Little Rock. He said, I'm bored now. So he came and looked, and after he convinced his wife, Mary Grace, that she should come look at Little Rock, they came and loved it, and so that's been a great addition. Our foot and ankle team, Rob Martin and Chelsea Matthews. Rob was in my previous group, moved over when I did. Chelsea trained here, then did her fellowship and came back this past year to join us. They have a booming foot and ankle practice. Rob has been going back and forth to Northwest Arkansas as well, so it's been quite busy. If you look at our hand section, you see we have 6 surgeons who do nothing but hand and upper extremity surgery, and they are dynamite. For the first time about 5 years or so ago when we started building the team, was the first time since I have was a resident here way too many years ago that we could say that any hand injury in the state, including the replantation of hands, fingers, etc., could be done in our state. So nobody goes to Louisville, St. Louis, or anywhere else for hand injuries now because this team can handle everything. They also do brachial plexus. John Bracey and Mark Tate do. Brachial plexus injuries are very complex procedures that happen in the nerves coming out of the neck and down the arm. And so we are a regional referral source for this. So some of the big name medical centers in the South send their problems with brachial plexus injuries to Little Rock. So a great team. John Bracey, Shay Brannon, Tom Frazier, Sean Morrell, Mark Tate, and Teresa Wyrick. Orthopedic oncology, as you know, the Cancer Institute here is extremely important to not only our institution but our state, and we're fortunate to be an active participant in that. And our department is actually housed in the Cancer Institute at this time. Dr. Rick Nicholas, who is unfortunately retiring. Today is his last day at work. So we will miss him. He's been a great leader for our department. He's done a lot to build the orthopedic oncology program. Corey Montgomery is the other oncologist who will be leading that section now. We just hosted a potential new hire in orthopedic oncology. She and her husband and child spent Sunday evening with us discussing the position, and then spent the day with us yesterday. So we will fill this position with a person who is right for our state and right for our team. Orthopedic spine, Rick McCarthy, who many of you know, has done lots in pediatric deformity work and has also done some adult spine work. He's accompanied by David Bumpus and Sam Overly. The spine surgeons work in the spine service line, which is actually a part of the neurosciences service line, and David Bumpus leads the approach in spine for the campus, and they've done extremely well. You saw the awards they've won, and they've also excelled in publishing research related to spine. Orthopedic trauma, as you know, we have the only level 1 trauma center, and it is a busy place. Well, children's is level 1 as well, but only adult level 1. Steve Cherney leads our trauma team with Regis Renard and Rob Garrison. Rob Garrison just decided to make a major move that is a huge move for our department as well. Dr. Garrison is going to become chief of the VA service for us, which means that our residents will have some outstanding education at the VA, and our veterans will get incredibly good care there. Rob is totally committed to care at the university as well, and so he will continue to take level 1 orthopedic trauma call at UAMS while being at the VA. So we're excited for his move. We think it's great for our program, great for our residents, and we look to hire another orthopedic traumatologist, and we already have our eyes on her. As far as pediatric orthopedics is concerned, Brant Sacklaben leads this section. He's accompanied by Drs. Dale Blazier and Dr. Brian Ravenhorst. They are the only group of pediatric orthopedic surgeons in the state and do an incredible job. As you can imagine, they are very, very busy. There are lots of monkey bars in this state, and those monkey bars lead to upper extremity injuries that keep these doctors very busy, as well as taking care of the standard pediatric orthopedic problems. You'll note the star beneath them with 3 other names. We have 3 new pediatric orthopedic surgeons joining us in the next couple of months. Jordan Gross, Scott Schoenleber, and Adrian Coder will be joining us. Note that Adrian will be leading our team in Northwest Arkansas at the Arkansas Children's Hospital there, and working very closely with our adult orthopedic surgeons in Northwest. Shoulder and elbow, led by in our Northwest Arkansas division by Wes Cox, who is the chief of that division, and Chad Sonji, who trained here and did his fellowship at Mayo. Justin Rabinowitz will be joining us in a couple of months as well in our Little Rock location, and we have an offer out to another shoulder surgeon to join us as well. So the practice continues to grow. If we look at sports medicine, we have teams of sports medicine doctors in both Northwest Arkansas as well as Central Arkansas. In Northwest, Larry Baye and Ramon Ilanen are our primary care sports medicine doctors, the non-surgeons who take care of athletes and non-athletes, and those of us who wish we were more athletic. And we also have Tyler Carley, Naveen Kalambi, and Brad Reeves providing care. And Brad deserves a little explanation. Dr. Reeves and I were classmates in medical school. He did his orthopedic training in Jackson and then fellowship in Oklahoma, and then practiced in Joplin, Missouri, and then in South Dakota. And he was ready to move home, slow down his career. He does some crazy things. He is the surgeon for the MMA, the mixed martial arts fighting, Well, he does that around the country, and he still flies back to do their surgical care. But in our practice, and he works as many hours as most of us, he does non-operative care and spends his time on the sidelines taking care of athletes at that level. He has been absolutely huge for us as we care for the Razorbacks. If we look at our Central Arkansas team in sports medicine, I'm sorry, Lauren Poindexter joins us a couple months. Lauren is a physical medicine rehabilitation specialist who did a sports medicine fellowship as well, so she'll add to our non-operative team in Northwest. In Central Arkansas, Michael Cassad and Catherine Nance are our two non-operative sports medicine docs, and then Larry O'Malley, Chuck Pierce, and Jack Vanderschilden are surgical colleagues in sports medicine. So as you can tell, we have an incredible team of docs. We get along very well together, and we all pull in the same direction. My common line is, nobody has to work as hard as I do. I just expect everybody to be pulling in the same direction. And fortunately, we are blessed with an incredible team, which means that you and citizens who live in Arkansas are blessed by a great team of docs to care for them. You have probably heard that we're extremely excited about the Orthopedic and Spine Hospital that is being built on campus. This is a separate building that is dedicated to the care of orthopedic and spine patients. We'll have 24 private rooms for those who stay overnight, because it will be an inpatient hospital area, so patients can stay over as part of their inpatient stay, or if they need observation for a night or so. We'll have a small clinic area, 12 examination rooms for orthopedic trauma, orthopedic oncology, as well as for physical medicine and rehabilitation, as those doctors will be seeing patients in our building. And it'll be a place that if a surgeon is operating that day at the center and needs to see a patient, he or she could meet them in the clinical area. We'll have 12 operating rooms dedicated to orthopedics and spine, with the ability to add 4 more rooms in the future as necessary. Pain management will be moving to the facility. We'll have 8 exam rooms and 2 procedure rooms for doing pain medicine injections and procedures. We're excited to have a new imaging location. We'll have a 1.5 Tesla MRI, and as well as shell space for another 3.0 Tesla MRI in the future. We'll have fluoroscopy, CT, extremity CT. This will be the first weight-bearing extremity CT scan in our state, and we'll also have some low-dose radiation 3D measurements with something called EOS that we have in our outpatient offices now. And we'll have our radiology colleagues who specialize in musculoskeletal radiology will be housed in the building as well. And they'll have a reading room there so that we can have collaborative review of these x-rays with them, between us, our learners, and them and their learners. In addition, this will become our true cultural center for our department. Our faculty and offices will move there, as will our resident education space. And we think this is just going to be great for all involved. You'll be there when you're doing work in your office. You'll be in the building when you're operating. You may see some clinic patients there, and we'll see each other more. The one downside of the distributive clinics is we often go weeks without seeing some of our partners, so this will improve that. This is some artists. We have a few artist renditions of what our building will look like. We're excited. It is a different look for the campus. It is a modern building with as much glass as I could convince everyone to put in, because I think it adds a real nice look, as you will see. And this is the north elevation of the building, obviously modern and a different look than we're used to, and it is laid out beautifully. Cromwell is a local architect working with a group out of Nashville who specialize in orthopedic centers. So we are getting absolutely a great team effort in the design, and Nabholz is doing our build. So we're very much looking forward to that. And you'll see the signs from Interstate 630. If you drive by, you can see where the building will be. I can tell you that it's been a long time coming. I only started asking for the building before I signed my contract, and we got approval, and we turned dirt a couple of months ago with a shovel, for the groundbreaking. As soon as we finished that, I walked over to the project leader for Nabholz and said, can you all turn more dirt this afternoon? We've got to get this show on the road. So we're looking forward to being there in about 2.5 years. But it's a big facility. It's an $85 million facility. So it is a major commitment from not only UAMS, but the Board of Trustees and the U of A system. And we cannot thank them enough for their confidence in what we can bring to our state through this expansion. In Northwest Arkansas, we continue to grow. We have 8 doctors. We're adding 2 in September, as we talked about. So we'll have a 10-doctor group in Northwest. 6 years ago, we had 0. Actually, 3 years ago, we had 0. So we're excited about that. I mentioned the Razorbacks. One of the other goals I had when I came over was that the leading orthopedic group in the state should be taking care of the largest and the most popular and our own athletic team. I'm glad to say that we now take care of the Razorbacks. We started that in January. So we take care of athletes for all the 19 sports. There's a little over 465 student athletes. Just as importantly, we take care of every team that UA has almost. We don't take care of UA Fort Smith yet. But otherwise, we're taking care of every team in this system, and we think that we're the folks who should be. We also have a booming high school sports medicine program. We're partnered with Arkansas Children's Hospital in both Central Arkansas and Northwest. It's on the slide here because it's new in Northwest, and we've just taken over some of the major high schools there to provide their care, so we're very excited about that. We are also working on a new facility there. It should go to the Board of Trustees soon. They have already given approval to start the process with, and we have an architect working on that. So that the architect from Nashville has partnered with a local team in Northwest Arkansas, and so we're very excited about that. And they'll work with the architecture school at the U of A as well. So we think that'll be wonderful. It will be an outpatient facility. It'll be dedicated to orthopedics. It'll have operating rooms, clinics, space for therapy, imaging, as well as sports performance. So we'll soon have about $170 million worth of orthopedic and spine facilities under the UAMS banner in our state. And I think it will help us totally transform orthopedic care in our state. I mentioned innovation and collaboration. We are very dedicated to research. We believe that in addition to education, that's what makes us different by being at an academic center. We are very much want to be on the forefront of what's happening in musculoskeletal development. So we have a biomechanics lab looking at so we can study cadavers, et cetera. We have with a major commitment there early in my tenure of about $350,000 of what's called an MTS machine so we can do testing. We do biomechanics, histology, and imaging. We have a micro CT, so a very small device that will do CTs of small animal bones so we can look at the response to stress, et cetera. And we also have a motion analysis laboratory that is in the western part of Little Rock, so off campus. You see that Jinhu Zhang listed here. I am glad to say that he is the first basic scientist to have an NIH grant in the Department of Orthopedics. And so we're excited about that, and our goal will be to have many more. John Sherrill is with us as well. He's looking at in his postdoc doing biomechanics of the spine and 3D custom printing, and is in a special entrepreneurship program on campus also, so we're having fun with him. We've got a couple of total joint products that he's helping develop. So we also have the human motion analysis area that we talked about. And none of this would be possible without some very, very nice support that we've had to our research. Special thanks to Bill and Betty Petty. They have just been extremely benevolent to our department. And Dr. Petty went to medical school here, subsequently was chairman of orthopedics at the University of Florida back when I interviewed for residency positions, and then started a company called Exactech, selling orthopedic implants. Started out of his garage, and it's now a multi-million-dollar company. He and Betty is from Hot Springs, have been kind enough to support us. Mike Gibson through the Judd Hill Foundation has been a great benefactor for our department as well. And the nice thing is these donations have been toward research because they understand that's what changes the future, and we appreciate it. So some of these collaboratives, we have a bone and joint initiative. When I first got here, I understood that my predecessor, 2 or 3 before, really thought that only orthopedics should be doing bones. So there was research that there was some kind of conflict between the Department of Orthopedics and the metabolic bone disease area. So I quickly went to Stavros Monologos and listen, if there was some competition, we lost. You have $50 million worth of NIH funding and we have 0. So you win. Can you do a partner? And he was absolutely incredible and very supportive of the partnership. That's why we now have funding of basic scientists by the NIH. And the chancellor at that time and the dean were very supportive and funded our bone and joint initiative. And then Charles O'Brien started the Center for Musculoskeletal Research. We have COBRI funding through it. So NIH funding that helps young researchers become self-funded. Again, the same process that led to our funding, and we have 5 researchers who are currently funded through the COBRI. Mark Smeltzer is an international expert in bone infection, and we're fortunate to have him on our team. He's in the microbiology department, but works very closely with our department. Mark was working in the lab in Kansas a number of years ago, 25 years ago or more, 30 years ago, I guess, and Carl Nelson called that lab. Carl was chairman here when I was in training, called the lab and was talking to the director he knew, and Mark tells a story that the director covered the phone and said, anybody want to move to Arkansas? And Mark raised his hand. They didn't know he's from El Dorado. And then he got off the phone. He said, Mark, you're going to move there and do osteomyelitis work. Mark's first question was, what is osteomyelitis? Now he's the international expert in osteomyelitis and infections related to orthopedic implants. Scott Lynn is our new addition. Dr. Nelson was innovative in his time. He had a chair started that was a chair for innovation, and so we have some funding to do innovative things. And so our first chairholder in that area was in health literacy. Christy Haddon did a lot of writing on health literacy and working with our department, and I guess we wrote 10 or 12 articles in orthopedics about health literacy, what patients can understand. But now Scott Lynn is working with us from Cal State Fullerton. He is a golf biomechanics expert, and we've been doing research in the last few years looking at the golf swing and its effect on the hip, the knee, hip and knee replacements, as well as the spine, and Scott will take us to another level there. Rebecca Samsanraj is at the U of A. She is now working with us and is funded through the 1, 2, 3 Go program here and also through our COBRI. And she is an expert in stem cells. So we're very fortunate. She had been working at Mayo, and she moved to Northwest Arkansas because her husband was fortunate enough to be hired by one of the big companies in Northwest Arkansas. And so she is now working closely with us and will take us to another level in stem cell research. Christy Haddon already mentioned. Alex Biras is a nanotechnology specialist and specializes in bone regenerations, and he is at UA Little Rock and works very closely with us. We also have a relationship with Jeffrey Walchuk, a PhD in biomaterials for muscle regeneration at the U of A in Fayetteville. So you can see that we truly have collaborated with as many people as we can across this state and across this institution, because we totally believe that this is not something that can be done just by the people in our department, and that we should be working together with others across the state. Stavros, I mentioned, Stavros won the international award a couple of years ago for his work in osteoporosis, and we're glad to call him one of our partners. Charles O'Brien, I mentioned, he leads the COBRI, which is will soon be up for renewal, and there's $25 million worth of funding that is significant to our campus and to the departments it represents. Mark Smeltzer here seen getting his chair. Again, a great addition to our research team, and Scott Lynn, who truly is not 16 like he looks in his picture, but is an expert in biomechanics and golf research, and our expert in stem cells, Rebecca Samsaraj. So we talked about research, we talked about clinical care, we talked about our expansion. We're here to educate people too, right? So we're very fortunate that we have some incredible residents who trust us with their education. For the first 40 years or so of the institution, we had 4 residents per year. After, I guess, a year here, we applied to increase our number of residents, something that's not allowed very often at the national level, but our volume had grown so much already. Before I got here, we were doing about 1,100 adult operations a year. Even without our new facility, we're doing almost 8,000 a year now. So it is a busy practice. And so we could show that we had the volume that our residents could learn from that. And so we were able to get approval to increase our residents from 4 per year to 6 per year. Interestingly enough, the residents, we took it to our residents and they asked us not to go to 6 yet, but to go to 5 because our culture is so important. And we have a great relationship among the residents, but also the residents and the attendings here. And so they were concerned that too big, too fast might be a problem. And so we increased to 5, and we may never go to 6, but fortunately we have the ability to do so if we need to. And I can't thank leadership here enough because while we had approval to go to 6, CMS doesn't fund new residency positions at an institution that already has a resident program. It would be political for me to make a comment about that, but I think you can imagine that it's less expensive to add someone at an institution than it is to start anew. But we are fortunate that our leadership here supported the expansion of our program. So we currently have 25 residents. We have over 500 applications per year for 5 positions. So orthopedics is extremely competitive. We have 5 new interns starting with us now, and we're excited that they're here. We are glad too that we have a very diverse resident group. We are one of the leaders in the country as far as having women being educated in our program, and we're very proud of that. And so we have broad exposure to all the subspecialties. We train at, in addition to here at UAMS, at Arkansas Children's Hospital and the Little Rock VA. Our residents do not train in Northwest Arkansas. They will have elective time there if they choose in the near future. We traveled some when I was a resident, and it was a requirement. And I am steadfast that we don't have to do that. We want. If we can do everything here, it is so much easier for the residents and their families if they're not leaving for 6 weeks or 3 months to do a rotation elsewhere. We've had 100% pass rate over the boards over the last more than 10 years, and we have a strong network of alumni, both locally and nationally, so we're glad of that. We have the responsibility of teaching medical students as well, those who do elective rotations with us, and we're also interested in diversity in this area. We have students come rotate with us from away location, med schools looking at our residency program. We started a scholarship program. It was supposed to start this year. Unfortunately, COVID made it so that we could not have visitors this year. But it's for scholarship support for diversity students, underrepresented minorities, to do rotations on our campus with us. And I can't thank Jack Vandershield enough for his support of that, use some of his chair money to support that process. And again, we have adult reconstruction and spine fellows. So education at all levels, including educating one another. I talked about the importance of leadership development into our department. About 3 months ago, I named 4 vice chairs because I think it's important that these young men and women have an opportunity to start leading sections because all of them have the potential to be a chair, whether here or elsewhere in the future. Obviously, couldn't all 4 of them be a chair here? I mean, there are others in our department too who could step up to that role. Some have decided maybe it's not what they want to do, but it's David Bumpus leads research for us, Steve Cherney, education, Simon Mears, safety and quality, and Teresa Wyrick, faculty development. And I'd be remiss if I did not mention Paul Stover, sitting there next to me. where he often is, usually in front of me, making sure I get to where I'm supposed to be and that I have everything I need. Paul is our administrator, and I've never worked with an administrator like Paul. He is, first of all, we understand the difference between management and leadership, and we understand when we get in each other's way in those areas, which is important. We have that relationship. But I tell people, I don't think I've ever been to a meeting at UAMS when something was going to be negotiated that I didn't have more data than the person with whom I was negotiating, because Paul Stover knows how to get what we need, and he gets things done for us. And the growth that we've had would not have happened without him. I would also like to share with you something that we've started. As I mentioned, Carl Nelson, Dr. Nelson was the chair here for many years, trained me. I used to say we couldn't have an orthopedic meeting without mentioning Carl's name. It used to bug me. Now I say it all the time. And then I named an award after him. Dr. Nelson was early understanding the importance of having women in orthopedics. We had women at the University of Arkansas for Medical Sciences Orthopedic Department 30-something years ago, and we were training female residents at that time. It was happening in the country, but not too many areas in the South at the time. So Carl was ahead of his time. Now it's very important to us nationally. We all recognize it. So we started an award this year that we'll give in 2 months to the institution in the United States that we think has done the most in that year to advance careers of women in orthopedics. And that concludes my talk. I told you I could talk for hours about orthopedics. I'm sorry I shared so much information in such a short period of time, but I think there may be some questions, and I'm happy to answer those as well. But do you have the microphone?
Thank you so much, Dr. Barnes. And yes, we do have questions. So I will read each one of them aloud as time permits. The first question, once the new surgical hospital opens, what will be the biggest benefit for orthopedic patients?
That's a great question. So we think the real benefit is to have so many things related to orthopedics in one location. So you'll have, as we talked about, imaging, operating area, clinical space, and surgeons working there together on a daily basis. So it'll be a very collegial place where if there's a tough problem, there's a colleague close by to, hey, what do you think about this? And you will know that you're going to the most advanced center in our state.
Thank you. Next question. What advances will we see in orthopedic surgery and care over the next 5 to 10 years?
That's a great question. So, I rarely have a clinic when I'm not asked if I'm going to use the robot to do their total knee. The answer is no. But if I were to be asked that question 10 years from now, the answer might be yes. The robot has not changed practice yet. It may in the future. But right now, we still need more technology to go with us. It can take it through all the steps, and it can make the bone cuts, but it doesn't balance the knee well enough. And I tell everybody that the knee replacement is a soft tissue operation, and what's important is getting the knee not only aligned correctly, but getting the balance right. Just like tires on your car, they're aligned but not balanced, they don't last as long. So we don't have the technology to do that yet. We may have it in the future, and then you'll see more and more advances like that. I actually went in and watched David Bumpus and Sam Overly do a spine operation about 3 weeks ago, and they were using computer-assisted surgery. So that means something you can do in a spine. You come in, you use the O-arm. It's like a C-arm type scan of the body with a marker in place in the lower spine, and then you can register the bony anatomy in the computer so that when you get ready to place a screw into the pedicle, the very small area of bone in the vertebrae where the screws go, it just puts you in the right spot every time. So totally changed that operation. And so as we'll see more and more advancements like that, I think we'll see imaging advancements. I mentioned the EOS machine. That is a scan that we use now. where you stand in a telephone type booth, and with very low radiation in a matter of seconds, it can give you a scan of either your spine to your hips or your hips to the ground, and you can see the alignment not only in 2 planes, but it can do a 3D reconstruction of that, so you can see the imaging very much like a CT. We'll also have weight-bearing CT scan, so that especially our foot and ankle surgeons can look at the hind foot, that area just below the ankle, and to stress how that is different when weight is applied to it and how that may impact care. We'll probably see some advancements in osteoporosis imaging that will also may be incorporated there. Again, I shared with you that our metabolic bone disease team are international experts, and I think we'll see advancements there. The nice thing in our center, too, we're going to have, I could talk about that hospital for a while, as you know. We're going to have some things that are different than any place in our state, and that the communication system will be great, so that we'll be able to communicate and teach from the operating room. We'll be able to we have a viewing area where family members will be able to come into the operating room and look through the glass walls to 4 different rooms. Obviously, you can only see the one that you're supposed to see, so that you can see what the surgeon is doing, and he or she can talk to the family and explain the process. And that's based upon something Dr. Jim Andrews developed at the Andrews Institute, and his patients love it. We visited there, and we're using the same architect, and he's incorporated this in other centers because it's good for the family, it's good for the patient to understand what's going on.
I love that. Thank you.
Thank you.
The next question. So many ortho clinics are in Little Rock or Central Arkansas. What plans are there to expand to other areas of the state?
Great question. Unfortunately, a tough question, too. We know that we have disparities of care in our state. We have to do better serving those areas that can't get the orthopedic care they need. We're excited that one of our graduates, she's actually spent an extra year with us doing a fellowship. She's been working with us to work at the Baptist Hospital in Conway. We provide all their orthopedic care there. Stacy Calloway's been working with us there for an extra year because she truly is going to be an outstanding general orthopedic surgeon who can do most everything that we do, and she's moving to Forest City. And so we'll continue to work very closely with her. It will not be a UAMS clinic, but we'll work closely with her to help provide the care in that area. We'll continue to work with our regional programs and are looking at satellite clinics around the state. We know that's something we need to do.
Great, thank you. The next question that's come in, what do you see as the next frontier for orthopedic medicine, and what challenges need to be overcome for us to get there?
Great. So first, stem cells. We'll see stem cell research lead to the better and more appropriate use of stem cells. Right now, when patients come in, they talk to me about injections, often confusing about, is it PRP? Is it a true stem cell from a marrow aspirate? Is it a stem cell from adipose tissue? Is it amniotic fluid they've had? And unfortunately, the cost is all over the board. It wasn't long ago that I saw a man and woman, husband and wife, who in their 70s, and they had gotten a discount, and they got all four of their knees injected, and the person who injected their knee gave them a discount that they did it for $17,000 or $18,000 instead of $20,000 at $5,000 per knee. And they were both there to get their knees replaced because they were long past being helped with stem cells. So it's important that we figure out and educate others, when is the right time to use stem cells? How do we know that we have the right stem cells? We know that as we get older, our stem cells don't do the same thing. So if you're 75 years old and you're getting your stem cells taken out of your iliac crest, the chances that they're going to be as good as if a 40-year-old is getting stem cells placed around an area are markedly different. And we will learn more about how those stem cells might be manipulated so they could be more proliferative if they can help the person. We'll probably also be looking at genetic therapies as we learn more about genes that affect arthritis progression, et cetera, but not there yet. And certainly we'll see more biomaterial advancements. We continue to work in that area, looking at which implants can have the longest livelihood, how long can they last. Additionally, we'll have implants that hopefully have treatments that help prevent infection in the future. One of the real challenges is if you have an orthopedic implant that gets infected, it often has to come out to get it well. And that's because there is a glycocalyx or slime that the bacteria produce that stick to the implant, and right now you can't get them off. So there are a number of treatments being looked at. One, how can you prevent that glycocalyx from ever forming if an infection were to happen? And two, if it were to happen, what can you do to treat it either non-operatively or operatively to get rid of the glycocalyx so you can treat the patient, get them well with antibiotics alone? And so lots of things coming down the pike.
I'm learning a lot. I'm glad these questions are coming in because I'm learning a lot. This next question is around COVID-19. COVID-19 has made virtual health visits a necessity for many. As Arkansans begins to shift back to a new normal, how big of a role will virtual health play in orthopedics going forward?
Danielle, that's a great question. And, we really don't know at this time. Certainly, it was major for us when it had to be, because that's all we could do except for emergency care. But what we do is a very visual field. We need x-rays for most of what we do, especially with new patients. And so one thing we'll be doing, looking at for patients who need to be seen virtually, can they get their x-ray locally, upload them to us, and then do the examination over the internet with them, and then to follow up. Certainly we do follow-up visits now in a telemedicine approach. And it's kind of all over the board, as you might imagine. The older docs, like me, don't do it nearly as much as the young doctors. But certainly it can decrease the amount of follow-up visits to Little Rock or to Northwest Arkansas because we treat patients from hours away. And nobody should have to drive 4 hours to come in, see me for 30 seconds or 2 minutes to make sure their wound's okay, unless they just want to be checked. If they can do that in a telemedicine type approach, so much better. We will certainly be using telemedicine for physical therapy. We know that remote therapy can be done after joint replacements. We don't do therapy routinely for hips, but we do for knees. And so we can limit the time that patients have to go into therapy.
That's good to know. My dad just had physical therapy, and that was before COVID. So I'm sure he would have loved to know that that's something that would be available after the fact. What preventative measures, I like this question, what preventative measures do you recommend for patients to help them avoid orthopedic issues in the future?
Great question. Well, certainly from a bone health standpoint, bones respond to stress. So if you want to have strong bones, weight-bearing activities like walking are good for your bones. Having a good diet, being overweight, unfortunately, is not good for your overall health, though, so you need to think about that. It places an increased load on your lower extremity joints. It can lead to progressive arthritis. Muscle strength is important, so it's stay fit, stay healthy, and have a good diet. I'm sure you hear that about everything, not just bones and joints, but they all tend to run together. And believe it or not, smoking is not good for your bones either. We haven't found anything it's good for.
Do vitamins or supplements help?
Great question. We don't know of any vitamins or supplements that help just to help bone health, but certainly deficiency of some vitamins can. We know that unfortunately too much of the Arkansas population has vitamin D deficiency. So it may well be that some of the population needs to be on vitamin D supplementation that does not get it.
And the last question that's come in today, what are the pros and cons of having a metal plate and screws removed from a wrist that has been broken?
Oh, great question. So, why would you have a plate and screws removed? The main reason is if you're having pain there, right? So oftentimes, because there's not a whole bunch of soft tissue over the wrist bone, the plate, you can feel the plate there, it can get irritated, and that's the reason to have it removed. If you're If you're a child, you're 12, and you get 2 plates put on your forearm, you often have those removed because you worry about they're causing problems later, fracture below, fracture above, et cetera. Some hardware around the hip, we recommend that you get it removed if you have realignment procedures, because we know that those procedures buy you time, but they don't prevent hip replacement in the future. So getting that plate out will then make your hip replacement a little easier in the future. In most areas, though, we say if the plate's not causing a problem, we leave it. So.
Good. Thank you so much, Dr. Barnes. That was our last question. I really appreciate the information that you shared today, and I want to thank everyone else for tuning in. I know you appreciate the responses you've heard and the information you heard about the growth of the orthopedics programs here in UAMS. I also want to remind you that our next Lunch with Leaders event is going to be July 23rd. We have Dr. Paul Phillips. Dr. Paul Phillips is our chair of the Department of Ophthalmology and director of the Harvey and Bernice Jones Eye Institute. You will be receiving an email soon with information on our next Lunch with Leaders event. Again, thank you so much, Dr. Barnes, and thank you all of you for tuning in and hearing us today. Have a great afternoon.
Thank you all.